Welcome. I am Dr. C. I am the creator and founder of EPPP with Dr. C, and I'm giving you a preview. We are talking about trauma and stressor-related disorders, and this is a subcategory as part of our mental health diagnostics domain. Let's check it out. Starting out with panic disorder. So there's a couple different key hallmark symptoms, and I bolded them because these are the ones I think that we commit to memory. So panic disorder, there is a recurrent, unexpected fear of these panic attacks. So the fear that another panic attack can occur, even if nothing really triggers it. There's also an abrupt onset. So again, nothing triggers it out of the blue. Suddenly it's occurring. Physiological symptoms. So increased heart rate, dizziness, temperature changes, nausea, sweating, and similarly, the continuous concern. So, oh my goodness, when am I going to have another one of these debilitating episodes? And then last but not least, there's avoidance behavior. So avoidance is something that, especially if you're working with trauma, you are going to encounter. So avoiding certain situations or triggers that the person believes could bring about another type of either a panic attack, symptoms of the panic disorder, or worsening the disorder. With agoraphobia, really the primary concern is the fear of not being able to escape if something happens when you are either experiencing anxiety or panic. So it's almost kind of like I am stuck here and I cannot get out. Physiological symptoms are similar to panic disorder. So a lot of the physiological increased heart rate, dizziness, nausea, sweating, tingling. And then we also see similarly avoidance behavior. So certain situations that you fear that you can't escape, enjoyable activities that you once engaged in, because again, the fundamental fear is I am trapped and I cannot get out and I am going to experience these physiological symptoms. Not surprisingly, we already kind of covered these, but a lot of similarities between panic disorder and agoraphobia. So similar physiological symptoms, similar acts of avoidance in effort to avoid said physiological symptoms, and similar treatment interventions. So a lot of exposure-based treatment. When we're dealing with a lot of avoidance, oftentimes the answer is, and I'm kind of this camp of then we go into exposure. The only way out is through. So that can look like CBT, that can look like ERP, but really fundamentally facing the avoidance there. The major difference, though, between panic disorder and agoraphobia is the primary fear. So with panic disorder, it tends to be the fear of having another panic attack. With agoraphobia, it's really the fear that one cannot escape from these symptoms. So we see that as avoidance of public spaces, venturing outside the home. So it's really an escape fear. With panic disorder, it's these symptoms are going to happen again. I'm going to have another panic attack. So post-traumatic stress disorder, or PTSD, I was trained with veterans at the Veterans Health Administration in the States. And so I had a lot of prior experience treating PTSD. I don't work in that realm anymore, but I definitely remember a lot of these components. So the first component, and this is really the major criteria, is that you have to experience a criterion A traumatic event. And this is contested. This is there's polarizing. It's a little controversial, but per the DSM-5, you need to experience a criterion A trauma. So that includes experiencing a situation where you are exposed to death, threatened death, actual or serious injury, sexual violence, direct exposure to that, witnessing a trauma, learning that a trauma happened to a close relative, and then indirect experiences of details of this trauma, for example, first responders, medics, things like that. So you must have experienced an event that is under the umbrella of a criterion A trauma to meet the criteria of PTSD. That's not all, but that's the first requirement. Then you need to experience re-experiencing symptoms. So this is where we see nightmares, flashbacks, emotional distress after feeling triggered by a reminder, physical reactivity after exposure to the traumatic reminders. We'll talk about hypervigilance, but that's criterion B. Criterion C, avoidance. Like I said, name of the game, avoidance. So we're avoiding anything that reminds us of the traumatic event. So thoughts or feelings, events, locations, anything that reminds us of that traumatic event, that is avoidance. And so we will try to avoid any of those reminders. Criterion D, negative changes in cognition or mood. So maybe the inability to recall the traumatic event from start to finish, overly negative thoughts about oneself, self-esteem, exaggerated blame for self or others, causing the trauma, so self-blame, negative affect, decreased interest in activities that you used to enjoy, isolation, really having trouble with experiencing positive either emotions or experiences. This is all under the realm of criterion D. And this is key because this is one of the reasons why it's so tricky to do a differential diagnosis of PTSD and depression as well as adjustment disorder with depressive features, because some of these symptoms really have a depressive feel. However, when PTSD is involved, it's under the criterion D of negative changes in cognition or mood. Criterion E is arousal. So these are symptoms that either began or worsened after the traumatic incident, heightened irritability or aggression, risky or destructive behavior, so propensity to engage in risk-taking activities, driving really fast, getting into altercations that person typically didn't beforehand, hypervigilance, heightened startle reaction, feeling on edge, difficulty concentrating, and sleep-related issues. Criterion F is the symptom duration. Symptoms need to last for at least 1 month. Criterion G, level of impairment. So these symptoms have to cause distress in the person's everyday functioning, in social settings, in work settings. There has to be an impairment. Criterion H, rule out. So always important to rule out any other underlying causes for these symptoms. So these symptoms cannot be attributed strictly to substance use disorder or another medical concern or condition. Another component of PTSD, and this is not a requirement for diagnostic criteria, but it might be on board, either depersonalization or derealization. So with depersonalization, and I really see the person in there, essentially the person feels like they are detached from their own thoughts or their body. They're almost observing their own experiences or narrating it as they're going through life. So you might hear someone say, I don't feel real. With derealization, essentially, this is where the person's describing almost walking through life in a dreamlike state. So the world does not feel real. So with depersonalization, really, I do not feel real. Person, derealization, the world does not feel real. So, with acute stress disorder, we have some similarities to PTSD. So, essentially, first and foremost, we need to have experienced a criterion A event. The symptoms are quite similar to PTSD, re experiencing avoidance symptoms, negative changes in cognition and mood, and arousal. But here's the kicker, and we'll talk about this in a little bit, but duration. So, these symptoms have to occur 3 days to 1 month after the criterion A event. And it's important to really consider, why do we even distinguish between PTSD and acute stress disorder? Well, and this is not really well known, I would say, most people who experience a criterion A event or a traumatic event that would be under the category of criterion A trauma, they will not go on to develop PTSD. About 6% of individuals who experience a criterion A trauma may develop PTSD. So 94% of other individuals will not go on to develop PTSD. So acute stress disorder really captures the beginning stages, day 1, 2, 3, up until day 30, of similar symptoms to PTSD, but we need to give it that time frame before diagnosing PTSD. Similarities between PTSD and acute stress disorder. Both are trauma stressor related disorders that impact your mood, your cognition, arousal, reactivity. Both feature symptomatic responses to traumatic events. Major differences, though, between PTSD and acute stress disorder. So, symptoms PTSD does include non fear based symptoms, depersonalization, derealization. Acute stress disorder does not include these subtypes, but really the number one difference PTSD requires that you've been experiencing these symptoms for at least 1 month. Acute stress disorder requires that these symptoms have been experienced 3 days to 1 month after the traumatic event. So, after that window of a month, you can no longer meet criteria for acute stress disorder. And then we're going to evaluate and assess for what type of traumatic related disorder may this really be looking like. That's the key difference, is the duration and the symptoms. So I hope this was helpful. I know it was quick, I know it was fast, but it really is just to give you a preview of my style. I think I'm a little, slow it down a little bit more for recorded seminars, but essentially I just wanted to present on these topics. If you're interested, please visit our website, EPPP with drc.com. Under shops, we have a ton of really cool materials there. And thanks for joining us.